So good morning, good evening, good afternoon, everyone, from wherever you're joining us. My name is Masi Wanjala. I am the YDM lead, that's the Young Doctors Movement for WONCA, Africa Region lead. And it is my pleasure to welcome you this afternoon to our collaborative webinar with the Working Party on patient safety and quality from the World Organization of Family Doctors. Thank you so much for making the time to join us this afternoon for this webinar on enhancing healthcare quality and safety, looking at innovative approaches to improve service delivery, quality, and safety in primary care. And today we are joined by wonderful speakers, and most of them young doctors who themselves have had an experience working out how do we improve quality and safety within their primary care settings. And we will introduce them shortly as they speak. To start us off, I'm going to give a short introduction of what AfriWon is. So the World Organization of Family Doctors has a young doctors arm, specifically meant to give the young doctors a space to advocate for, interact, and develop their skills as they advocate for family medicine general practice within their various settings. And the AfriWon Renaissance is the African chapter of the World Organization of Family Doctors with a primary focus of supporting young and future general practitioners and family physicians in Africa through developing their capacity in research, in education and training, and advocacy as well, meeting their specific needs as African GP and family physician trainees. The Working Party on Quality and Safety, with whom we are collaborating, is one of the special interest groups on quality and safety, specifically in primary care, with a focus on advocating for and advancing patient safety and quality within the primary care safety through research, education, and training. And with that, I would like us to now dive in to the webinar with an introduction, first of all, on the objectives of why we're here today. So one is just to showcase innovative approaches and best practices in healthcare quality and patient safety implemented by young doctors, providing a forum for exchange of ideas, strategies, and challenges faced by young medical professionals in improving healthcare outcomes, here with a focus on the primary care setting. And then finally, just to strengthen the network among young doctors across the region for future collaborations on quality and patient safety projects. So our keynote speaker today, I have the pleasure of introducing Dr. Andrée Rochfort, who is the Director of Quality Improvement at the Irish College of GPs and Assistant Clinical Professor at the University College Dublin. She is the President of EQUIP, the European Network for Quality and Safety in WONCA Europe, and leads its working groups in professional health and in sustainable healthcare. Dr. Andrée is a family physician with over 30 years experience, a medical educator with interests in quality and safety, physician health, work-related well-being, sustainable healthcare and planetary health, patient empowerment, interdisciplinary healthcare, and telehealth. She is a founding member of the Irish Society of Lifestyle Medicine, the Sustainability and Planetary Health Working Group of the Irish College of GPs, and the European Association for Physician Health. She has qualifications in lifestyle medicine and occupational medicine, a master's degree in medical education, and a professional diploma in leadership and management. That is a distinction from the University College Dublin. She has delivered presentations on a range of topics internationally and has published, co-authored, and contributed to articles, guidelines, book chapters, and is a medical book editor. And I also would like to add, she is a very warm, inviting person and very supportive, especially of young doctors. And it's a pleasure for us to have her here today. And with that, I welcome you, Dr. Andrée Rochfort. You have the floor.
Dear Mercy, thank you so much for such a lovely introduction. And I'm really happy to be here, and especially with you and all of our AfriWon colleagues. As you were speaking, I was reminded that in 1985, 40 years ago this year, I spent a summer in Africa in near Meru on the foothills of Mount Kenya, several hours drive in a matatu up from Nairobi. And I've spoken to you about this already and the lovely memories that I have and the experience I had of making quality improvement activities with the medical officers in the hospital there. And thank you for inviting me today. I'm going to talk about leadership in quality and safety in family medicine, in particular in the light of the role of young doctors. And so in that mix, I'll be touching on safety, quality and prevention and the role of doctor engagement in terms of the quadruple aim. But I'll finish with a quotation and a story. So when we talk about healthcare quality, we keep in mind the 6 domains of healthcare quality from the Institute of Medicine: safety, timeliness or timely access, effectiveness, efficiency, equitable care, and person-centered care. Now, in family medicine and general practice, we are always challenged by these domains of healthcare quality. And we often have to trade off on different aspects for different patients as we are practicing person-centered care. And I'll come back to efficiency again because I would like to add in another domain, and that is sustainable healthcare. When we talk about efficient healthcare, we are considering the efficient use of available resources, including at times of diminished availability of resources, even abnormal times like a global pandemic. But efficiency of use of medical resources goes beyond the immediate boundaries of that. And when we talk about sustainable healthcare, it interacts with all of the other domains of quality of healthcare. Just to set the scene on patient safety, a definition, and there are many definitions of patient safety, as there are of healthcare quality, but the WHO has used this definition in its fact sheet. And just to set the scene so you can be thinking as we will hear 3 wonderful young doctors talking about the topic of today, that patient safety is a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare. And all of these factors consistently and sustainably lower health care risks, reduce the occurrence of avoidable harm, make error less likely, and reduce the impact of harm when it does occur. Because, as we know, there is no perfect health system and no system of healthcare that does not involve some aspect of uncertainty, clinical risk, and indeed harm. So it's about reducing the impact of harm when it occurs. And then just an introduction to leadership in quality and safety. This particular diagram is useful because it arose from a competency framework project. Competency in quality improvement specifically for family doctors. And at the center, when you see effective quality improvement, again, there are 6 domains here: equity and ethical practice, effectiveness and efficiency, continuing professional development, methods and tools, patient care and safety, and of course, leadership and management. And these domains were drawn up from an EQUIP project that EQUIP did with the College of Family Physicians in Poland back in 2012. And other than when we dig deeper under the leadership and management domain, we see that that includes GPs working in partnership with stakeholders at practice level, at community level, organizational level, and indeed national, regional, and national level. Leadership for quality and safety involves interprofessional teamwork. It involves GPs leading and knowing when to delegate, and it includes advocacy and negotiating change. And now just some very quick references. The Global Patient Safety Report 2024 from the World Health Organization is quite a big document. It's over 300 pages. So I've just taken note of 3 of the sections. I've just highlighted them here, and you can look at this document online, but I thought 3 particularly relevant areas was leadership capacity for clinical and managerial functions, patient safety in primary care and transitions of care, and learning from the patient experience. We all learn from the patient experience to improve safety and quality, and the patient stories are very strong and powerful. Leadership for capacity includes developing clinical and managerial capacity and capability at all levels. And we know from research and data that patient safety in primary care is less prioritized compared to safety in hospitals. It's increasingly becoming prioritized, thankfully, but only 17% of countries who responded to the WHO survey say they systematically included safety in primary care programs. For strategy 3.2, the medication without harm section is a strategy that is given high priority by the WHO, and I'll come back to medication without harm when I'm describing an activity very shortly. And this includes a schematic summary of the WHO 5 moments of medication safety tool. And in general practice, and with our recent experience of a pandemic, we had to implement infection prevention and control, and we continuously monitor our antimicrobial resistance as part of sustainable healthcare. And in terms of primary care and transitions of care, we know that improving safety in primary care can lead to better overall health outcomes and a more efficient healthcare system as we coordinate the care of our patients through those transitions of care to community care, hospital care, emergency care, out of hours care, and so on. So effectively managing all of those transitions is crucial. We are a very important part of the health system. In terms of priority for patient safety interventions, and there are a number listed there, I won't read them all out, but we can see that approximately 70% of countries have begun implementing at least one of the interventions. That could be safety culture or safety standards or patient and family engagement initiatives. And just under 20% reported implementation of all of the elements. So we have a lot of work to do, and we are looking to the young doctors to take this work forward, to work with us and to take it over. The Global Patient Safety Action Plan 21 to 30 highlights the need to assure the safety of processes, including diagnosis. And reducing diagnostic errors is a key strategy for improving patient safety. And they're the various 2 main types of diagnostic errors. And most adults will experience at least one diagnostic error in their lifetime. I was quite shocked to read this data from the Global Patient Safety Action Plan. And there are many factors that can lead to diagnostic error, systemic factors, but also cognitive and human factors, including clinician training and experiences, as well as diagnostic biases, fatigue, stress, and other influences. And this brings us to the triple aim, which was launched in 2007 by the Institute for Healthcare Improvement, by Don Berwick and colleagues, which aimed to address those 3 areas there: population health, patient experience, and cost containment, in an effort to make healthcare systems more efficient. However, for our purposes today, very important landmark paper was produced in 2014 by two primary care physicians, internal medicine and primary care, Thomas Bodenheimer and Christine Sinsky in the US. And they added in that we cannot have healthcare efficiency unless we improve the clinician experience, including clinician teamwork and clinician support. This was their paper, and I really invite you and encourage you to read it in full. It was built upon through enhancing healthcare efficiency to achieve the quadruple aim. You can now see that other researchers are including the well-being of the healthcare team in organizational efficiency of healthcare. And there are many examples of the quadruple aim in effect. For example, on the bottom right there, reducing the administrative burden to allow more time for patient care. It's a quest that we all face in family medicine, and perhaps we'll hear some more about that later on in this webinar. I'd like to share an example of a quality improvement project performed by 5 GP trainees in Ireland, working out of 5 GP practices in my own area of the island, the southeast of Ireland. And I know some of these trainees and have worked with one of them. And their project involved the Stop Frail deprescribing tool in nursing home residents attached to GP practices. Their project achieved a reduction of 31% in prescribed medication, and if it was extrapolated to the whole country here, it would have had potential savings of 13 million euros for the health service. And these trainees, leaders, young leaders in general practice, went on to win the research prize at the University Departments of General Practice Award 2022 and the Irish College of GPs GP Trainee Award for Quality and Safety in Practice. And that's the award on the right there. So the significance of primary care is immense. It's a cornerstone for robust health systems. And just before I finish, I have this article that I also encourage you to read. It's the relationship between practice quality and physician well-being and engagement. And this wonderful article shows that, in actual fact, doctors who participate more in quality improvement activities have greater job satisfaction and joy at work. And doctors who have better well-being participate more in quality improvement activities. So we have a very interesting relationship here. It'd be wonderful to see this research project repeated in other areas of the world. I'd like to finish with a quotation and a story. And I'm really honored that Dr. Maria Pilar Astier Pena from Zaragoza in Spain is with us on the webinar today. Wonderful to see you, Pilar. I know you're in Busan at the moment at a WONCA meeting, but it's wonderful that you could join us. So I asked some of my EQUIP colleagues. EQUIP is the European network of GPs for quality and safety in WONCA Europe, to join some of their thoughts, and I've asked Pilar for her permission to share hers. I find this very inspiring, and I'd love to have heard this as a young doctor, because I was a late entrant to quality improvement, officially quality improvement. So Pilar says, I began my journey as a physician in 1992. Early in my career, I was introduced to the quality circle and the plan, do, check, act cycle. This simple yet powerful tool changed my life. I applied it to every activity I undertook and quickly realized that quality in healthcare has many dimensions, and I've already outlined those. Safety is the foundation of quality care. It means avoiding harm related to the care we provide. These values have guided me throughout my career in helping me navigate personal and professional challenges. Over time, quality and safety became not just professional tools, but a way of living, essential to improving lives in our communities and around the world. To new family doctors, Pilar says, I encourage you to embrace quality and patient safety from the very beginning. These tools will be your companions throughout your career. They will help you to grow, support you in difficult moments, and lead you to connect with like-minded individuals, such as those Throughout this journey, I had the privilege of meeting extraordinary people such as those in EQUIP, who share these same values and walk the path of family medicine with dedication and hope. I'm deeply grateful to all those who taught and inspired me, and because of them, I continue striving to improve family medicine and the lives of the people we care for. If this was said live by Pilar, I think she would have a standing ovation. I think it's really inspirational. I'd like to finish with a photograph from my garden taken yesterday. You can see the daisies and the dandelions, and this symbolizes the pathway for all the young people on the webinar watching it live and watching the recording, because there's a beautiful blue sky ahead. And when you are active in quality and safety, it really brightens your way ahead. And I'd like to finish with a proverb from the Maori people. If you turn your face to the sun, the shadows will fall behind you. Thank you so much.
Wow. Thank you so much, Dr. Rochfort, for that wonderful, wonderful keynote. And it's a wonderful way, I think, to begin this webinar. And it's very, very inspiring. And what you've just finished with what Pilar said as well, is also very inspiring. At the end of the webinar, we'll have some time also to hear from you, Pilar, and to hear just a bit more of that inspiration of how you got onto the journey for patient safety and quality, and how it keeps inspiring you, and how you are also inspiring young family physicians who are coming up. And just to highlight one more thing that I found very interesting and inspiring is the fact that doctors or family physicians, you found that GPs and family physicians who participate in quality improvement and patient safety actually have even better mental health themselves and, like their job better. I think that is a very important tidbit that is backed by research, something to explore as well. And you've also mentioned that you're doing these studies and you'd also want to see how it would look like around the world. So I guess that is a conversation to carry on from this. So thank you so much, Dr. Rochfort. So our next speaker today is Dr. Inés Sebastián Sánchez. Dr. Inés is a resident, final family medicine resident in Zaragoza in Spain. And throughout her 4 years studying family medicine, she has increasingly recognized the critical importance of patient safety as a cornerstone of quality healthcare. And this interest has led her to participate in a study currently examining how physicians' own illnesses might impact clinical decision-making. And she has also been actively involved in several projects at her health center designed to empower patients in managing their own safety. And in her leisure time, she enjoys taking long walks in the countryside and dancing. And she also loves traveling and discovering new places and cultures. Welcome, Dr. Inés. Over to you. You have the floor.
Thank you very much for the introduction. I will now share my screen. Can you see it well?
Yes, it's visible.
Okay, thank you very much. So, good morning, everyone, and thank you for inviting me. It is a pleasure for me to be here and be able to learn from you all. My name is Inés, and I'm on my final year as a resident in family medicine. In my first year of residency, I made a mistake that I remember very vividly. During one of my hospital 24-hour shifts in the emergency department, I had a migraine. That shift was also a very intense and busy one, and I had many patients waiting to be treated. Because I was in a rush and not feeling well, I prescribed an intravenous antibiotic to the wrong patient. Without knowing in that moment, I was involved in these cognitive factors Andrée was just talking about. And I only realized about it an hour later, when I went to see how that patient was, and he asked me why I had prescribed it, because we had been talking about his pathology and it had nothing to do with an infection. That mistake, luckily, did not have a serious consequence, but it opened my eyes to this problem and others that impact on patient safety. As a student and during these 4 years of resident in family medicine, I have seen and also experienced other incidents related to patient safety, which have highlighted the importance of the study and promotion of the patient safety culture. During this presentation, I would like to share with you some ideas and some projects. So first, I wanted to talk about the impact of sick doctors in patient safety and in their own health. Second, empowering the patient to be the main actor of their health. And third, the importance of family medicine in multipathology patients, especially when they are not independent or in a nursing home. I would like to start with the impact of sick doctors. The importance of the health of the medical workforce has been increasingly recognized as studies show poor health can compromise performance and adversely affect standards of care. To become the patient when you are trained to be the doctor, it's not a learned experience and can sometimes lead to difficulties adapting to a new role. The peculiarity of the doctor's process of becoming ill is influenced by their knowledge, which incentivizes them to primarily self-manage their illness, seek informal help, or disregard adequate follow-up for recovery. That's why a group of Spanish researchers, mainly family doctors, started the project To Get Sick is Human, when the patient is the doctor. Through a national survey called the Spanish National Questionnaire on Behaviors and Attitudes of Doctors Towards Their Own Illness and the Management of Sick Colleagues, they analyzed the opinion of 4,308 doctors, 38 of them family doctors. And these doctors were of all categories, 9% trainees, 80% active doctors, and 11% retired doctors. The results I would like to expose are here. Both sexes primarily self-treat. It's 95% of all doctors. Most doctors went to work while ill. This is called presenteeism, and it's attending work when they should have taken a sick leave, and this is nearly 90% of doctors. More than half of the doctors recognized that their health problem had affected their professional activities in the last 2 years. Also, most doctors agreed that their health status directly affected the healthcare they provided daily. And nearly all doctors agreed that teamwork was essential for clinical safety and stated that they would try to find a solution if any team members were ill. So this last an important information, I will talk about it later. So this study show that we take risks regarding our own health, which at the same time can lead to problems in patient care. That's why we believe we should all be aware of these situations as well as how to deal with them in our daily life. After this study, the research group has elaborated some recommendations titled Learn to Take Care of Yourself to be able to take care of others, which I would like to show you here. From this picture, I would like to highlight that one of the recommendations for sick doctors and for doctors in general are get to know your family doctor, don't self-prescribe, keep yourself active, and don't go to work if you are sick. And I want to highlight that these recommendations are for all doctors. I think it's important to start this from the university with medical students, because we learn what we see, and it's what we are doing, what they are learning. So I think it's important that from the very beginning, we are aware of this situation. Going back to the story I shared about my mistake at the beginning of the presentation, Both the patient and the nurse were surprised to see that prescription, but the patient didn't tell the nurse, and the nurse didn't share her doubts with me, as the emergency department was really busy. When I realized my mistake, I apologized to the patient and his family and explained the situation to the nurse. I felt horrible for a long time and afraid of making more mistakes. When I shared this experience with other residents in family medicine, most of us had lived a risky event, some of them with more serious consequences. Sharing this experience with my colleague and especially feeling their support was very helpful for me and made me recover some confidence in myself and in my work. We believe that our colleagues' support when we are a second victim in this type of problems can be a key point to overcoming this type of difficult situations. Had the nurse and I communicated better, my mistake could have been prevented. Teamwork is one of the best ways of preventing mistakes in healthcare, in primary care as well as in the hospital. Also, when mistakes are made, analyzing together so that we don't repeat them is necessary. And this experience I had also connected me with the second idea I wanted to share. Why didn't my patient share his doubts about his treatment? That could have prevented the error. Until some years ago, we used to tell the patients, you don't have to worry about anything because everything is under control. This attitude is in line with the paternalistic medicine we have experienced during the last decades. And it was in last year's Patient Safety Day in Madrid that I heard the theory of a Spanish family doctor who has been studying patient safety in Spain. She is Rosa Añel. She applied the different human and system errors to the Swiss cheese model theory. It's clear that the patient is the person who better knows himself, and it's the only element, let's say, of the system that is present in all the different areas and levels. By empowering the patient on his own safety and making him the main role of his own health, we can see in the picture that he can identify risk situations before professionals. When I'm in my consultation in our primary care health center with my tutor Pilar, we try to make sure that the patient is aware and has an adequate knowledge of their illness, the medication they are taking, and what they are allergic to. Some of them carry this information in a sheet of paper to make sure they don't forget. This way, when they go to another doctor, maybe even in another region, where they don't have access to our patient's information, they can make sure they all have the best information in order to avoid errors, especially related to treatment. We also promote patients to be active in taking decisions that affect their health. With our team of patient safety from our health center, we are running some workshops about pain management. I'm showing you here some pictures we took on the last presentation. Usually we start talking about pain and different ways of dealing with it. We talk about pharmacological and other measures, so that each other knows how to act when a situation like this occurs. To finish, I think it is important that we talk about patients living in nursing homes, as they usually have more difficulties in participating in their own healthcare. Also, they are the ones that more frequently are taken care of in different centers and especially by different professionals. As family doctors, we are the ones who will see the patient through the years. It's the longitudinality. This takes us to a strategic point in which we can revise the medication, making sure they still need it and that no changes in dose or frequency have to be made. We also believe that working with primary care pharmacists has many advantages, as it provides a complementary perspective. In our health center, we have started doing some systematic reviews of the patients who are in nursing homes in collaboration with the pharmacists. We realized that there were problems related to medication, especially doses that had to be adjusted, medication that was no longer needed, and the intensification of medications to new targets according to age, for example, the diabetes control. These were the three main topics that I wanted to share with you: the impact of the doctor's health, empowering the patient, and patients in nursing home. From my point of view, it is extremely important for medical students, residency in family medicine, and young doctors that initiatives like this conference exist so that we continue learning on patient safety and getting ready for our professional future. Thank you very much to all of you.
Thank you very much, Inés, for that wonderful presentation. And I think as a young doctor, as a young family doctor, that's very inspiring because you're already doing so much just in residency to really improve patient safety and also just highlight the quality issues that we have within the system. I especially love how you started with sharing your story. I think that's important because that shows that we need to acknowledge to ourselves like the problems in the system, because it's not necessarily just a one-person problem, but a system problem, and how you identified communication as one of the things that could be done better. So I think you just started off with a lesson on how we should approach it, not as blaming each other or ourselves, but looking at how to do better. And I love how you are involving patients, empowering them, and your statement that they do actually know the dangers even better than we do. So thank you so much for that. I think we'll have a great Q&A session with you after this. Right now, I have the pleasure of introducing our next speaker. Our next speaker is Dr. Enwogo Ettang. Just to mention, he is the previous AfriWon chair. I took over from him and a great leader. And he's a family physician based in KwaZulu-Natal in South Africa with more than 16 years of experience in the medical field. He is currently in private practice, and his practice has a warm and very family-friendly environment, and the surgery is actually also part of his home, making it even more family-like and homely. And his interests are in diabetes, child health, men's health, female health, chronic disease management, and geriatrics as well. And he also happens to do house calls, telehealth as well, through both phone and video consultations to ensure that he reaches all his patients. And here to talk to us about how do you leverage technology for enhanced healthcare quality and safety. Welcome, Dr. Ettang. You have the floor.
Thank you so much, Mercy, for that lovely introduction. And good afternoon, everyone. As she said, I'm Dr. Ettang, and it's truly a pleasure and an honor to be here with you today. I'm grateful for this opportunity to share some thoughts on an exciting topic, which is leveraging technology for enhanced healthcare quality and safety. So I might share a few real-life experiences like she did, but let's dive in. All right, where do I move this cursor? Okay, so healthcare today is evolving faster, and I'm saying that even as a doctor working in, South Africa is a mixed population. It's got both some first world aspects and some rural or third world aspects. So, but I work in the rural part of South Africa, and complexity. Patients are also having higher expectations than before. So now there's a growing demand for both quality that the patients want and safety. And if you're working, especially as I previously used to work in the public sector until about a few weeks ago, where you have a high patient volume, you're trying to ask yourself now, how do I balance my time to see all these patients that have come in today so they don't go home unseen, but at the same time want to give them quality health, which is difficult, I'll be honest with you. So more than ever, I think that we have been tasked not only with just treating diseases, as doctors, which is what our primary training was on. But I see that over time, we need to also evolve in leadership training, because we need to get to the point where we can build systems, in our practices, so that we can also prevent errors, or to an extent, streamline the care that we give our patients. And at the end of the day, we should be able to promote trust from our patients, or with our patients. So I feel that technology, which some people are scared of, but when applied thoughtfully, it can give us a powerful tool to meet these challenges, in my opinion. So why does technology matter in healthcare quality and safety? And there are three things that I feel that three very important things. First one is efficiency. It improves efficiency in our practice, so that we can streamline our workflows with the use of technology, and to also reduce waiting times and minimizing the errors that we have. I remember in the hospital I used to work before, where a patient goes to do an X-ray. I mean, it's not in every center, but there are places where you do an X-ray, and then the patient has to go and print that X-ray, and then join the queue again to come and see the doctor, or wait for another appointment. But with the way technology is working, you can actually pick up some of those X-rays from your devices, especially here, and help to reduce the waiting time for these patients. Secondly, I feel that it improves accuracy. We are fatigued and we are overworked doctors, and sometimes we need to have a way to be able to diagnose things better. Sorry about that. And sometimes with technology, we can also leverage its capabilities, especially the diagnostic imaging, also to make safer clinical decisions when we are managing patients. And finally, in my opinion, it improves access, because we're able to reach patients that otherwise might have been left behind, or who are living in remote places where access is limited. So whether we work in a big hospital in the urban areas, or work in a small GP's practice, or you're working in a remote area, technology over time is reshaping what is possible. When I started my journey at telehealth, over the past few years, I've been privileged to work as a telehealth provider. Much more, I was doing on the side years before, but in the past 3 years, I've been very much involved. And I've been able to deliver care to patients, both in rural and urban areas. But when I started, my priority was more for the rural areas, because, for example, a patient does a blood test. I'll give a real life example. A patient comes to see me in the rural clinic, and they do certain blood tests. Our practice is such a way, or where I practice in the rural part of South Africa, where I practice, that sometimes we don't get some of those results on the same day. So the patient has to come on another day to get those results. Now, if the patient is coming on another day for those results, I've had patients tell me, "Doc, I have no money to come back tomorrow for this result. I'm a pensioner. I actually my budget is very, very tight. I will come and see you next month for the results." Now, if you're only used to face-to-face consultations, now how would you leverage technology to be able to now at least give counsel to the patient when the results are over? As I see that a lot of patients, even in the deep rural areas in the country in South Africa, have access to at least a cell phone. It might not always have the bells and whistles of WhatsApp or Zoom and all this stuff, but at least they do have access to a cell phone. And I can at least try and see how I can communicate with these patients. So for me, telehealth has helped me and allowed me to break down that barrier of distance, at the same time reduce the cost of care for many of my patients. And I can monitor many of these chronic conditions in real time using technology. So for me, through this, I mean, I've learned how much technology can, in my opinion, not just enhance access, but also give quality and reassurance and safety to some of my patients. Now, while telehealth contributes to patient safety in important areas or important ways, but first, by allowing consultations from home, one of the things I've seen that I'm able to reduce the patient's exposure to some hospital-acquired infections, especially those who are vulnerable in the population. I've had to start doing certain things in my inpatient practice because a lady comes just for renewal of her script for her blood pressure medication. But as she sits on the queue with a person who's been coughing for 2 weeks with constitutional symptoms for TB, now she comes in for just renewal, and she has a blood pressure machine at home. She has no complaints. She really has no need coming into the room except for maybe just a follow-up checkup on some of those things or renewal of scripts. So I feel that by allowing consultations from home in some cases, because we have to now leverage those cases, we can reduce the patient's exposures to some of our surgery or hospital-acquired infections. Secondly, I feel that early diagnosis and intervention can become very possible thanks to remote care and monitoring of some of our patients and follow-up of these patients when they are home. And thirdly, I think that patients, they feel empowered when they can reach out easily or clarify their symptoms and also avoid iterations without delay. So in short, telehealth is not just about convenience, but it's about a critical layer of safety when it comes to managing patients. Now, I'll give an example, a real-life example in my management of a patient with hypertension. So I had this patient at which I was giving an example where we were managing her blood pressure. She was a newly diagnosed hypertensive. And again, I've used it to kind of ask them to say, okay, submit your blood pressure readings remotely. And if the readings are trending upwards, I can try to adjust the medications promptly. And in that same environment where they are, I can also offer lifestyle counseling, for where they are, advise them on their diet, advise them on salt intake, advise them on physical activities. And this can happen virtually without even waiting for inpatient visits. And what I've even done is to even arrange for even group meetings where I give patient education for patients that have similar conditions. Now, these are not consultations, but just a Facebook Live or Instagram Live or Google Meets, or even using WhatsApp, which is what most of my patients do have, where we're able to give lifestyle counseling and education virtually without them all having to come to the room. And I'm able to reach a number of them in a short period of time. So for me, I feel that this proactive approach, it helps to reduce the risk of complications such as strokes or heart attacks. And for me, it helps me to transform my practice from just being reactive to treat what they're coming in with, but moving towards being towards preventative form of practice. And for me, that's a both win, both in terms of quality and safety. All right, as we come towards the end, telehealth is not just one piece of a large, it's just telehealth for me, I feel it's just one piece of a larger puzzle, because there are other technologies that are involved that are helping in shaping our care. The use of electronic health records, the use of clinical decision support systems that offer real-time guidance, like the point of care, which help to reduce both diagnostic and prescribing errors. I mean, when I use the app that we use for prescriptions, yes, I might not think at that time, but ideally I should, but it helps me to even pick up drug interactions with especially my patients that have multiple comorbidities, pick up drug interactions, that can help me to even adjust the dosage in the context of just drug interactions. And whether we like it or not, AI is here to stay. And we can find a way to work with it, but with safety, but with knowledge, because it's increasingly helping to sometimes predict patients' risk, and sometimes even before the symptoms even arise. So each of these tools, both the electronic health records, clinical decision support systems, and AI, they help to strengthen the quality and safety net around our patients. I mean, we've seen the growth in remote monitoring where the Apple Watches and the Samsung Watches are all becoming more useful in the healthcare field than before. Today, wearable devices can monitor glucose, can even give you real-time health data about your patients. Sometimes even patients that even devices that even help for patients with heart failure that can alert even me as a healthcare provider to give me early signs of decompensation of their heart conditions. So this ability to intervene even before a major event happens, it saves lives and also empowers my patients, to take more active role in their care. Even our patient portals, patients are able to see their results, and at least they feel that they are partners in their healthcare, as opposed to the previously paternalistic healthcare model where we just told our patients, they told them what the results were, we told them what we felt they needed to do, but now they feel that they are part or team members in their health. So they can see their results online. They can even have apps that help them remind them when to take their medication. And even using short video consultations, we can teach patients about their conditions and building health literacy and promoting even behaviors just by making short videos that we can put on social media. At the same time, we have to be cautious of what information is out there for our patient. But these things help to educate our patients. While we are seeing the growth in telehealth, we must be aware about the challenges involved. And one of the biggest challenges is data breach. No solution is perfect when it comes to managing health. We have to really confront real challenges, and data privacy and cybersecurity, these are major concerns, and we must do whatever we can to protect our patients' information fearlessly. So they are, and while we're trying to protect our patient information, there are also inequalities in our communities. Not everyone can afford a smartphone or smart device. Not everyone has internet access. And digital literacy for both patient and health workers, it can't get taken for granted. I mean, I have doctors who would not want to check patient results on the computer. They want it to be printed and brought to them in their hands. So if you're really serious about leveraging technology, you must also be serious about closing these gaps in managing health. So as we come to the end, what can we as young doctors do today? And the first thing I said, let's embrace technology mindfully, not using it for its own sake, but always prioritizing our patients' needs. Secondly, we need to advocate for our models to be patient-centered, so that ensure that any new systems that we are getting, they are accessible, they are respectful, and also at the same time, they are easy to use. And thirdly, I want us to push for equitable access, because the healthcare system must be one that leaves no one behind. Thank you so much for your attention. I hope that this session has sparked some ideas, some inspirations, and maybe even some questions. And hopefully at the panel end, we shall look forward to your thoughts as we engage in a lively discussion. All right, thank you. God bless.
Wow, thank you so much, Dr. Ettang, for that wonderful presentation and for really drilling it down for us to the patient-provider interaction and how you've been leveraging technology just to improve the quality of care that you're giving your patients and also their safety. I love how you have given a very good example for the African setup where normally at the primary care level, doctors are overwhelmed by patient numbers. So you're trying to balance between ensuring you see everybody, but at the same time giving them quality care. And you've shown us how you've leveraged WhatsApp and just cell phones to ensure that they get that quality, they get that attention, and you also empower them for their own safety to prevent, complications that could have happened had they not gotten that information from you. And I also love how you have emphasized a point that Dr. Inés brought up, the issue of paternalistic healthcare that we've had, and how you're using technology. You're changing that by empowering patients to have their own results, to be able to interact with them just as you would as a doctor. And I think those are wonderful insights and very inspiring, especially also your call to action for us to embrace technology to help us improve quality and safety. Last but not least, I have the pleasure of introducing our last speaker for the day, who is Dr. Armand Tiam. And I'd like just to mention that I met Dr. Armand a while back when we were coaches at the Institute of Healthcare Improvement Open School. And sorry, let me see. Yes, at the Institute of Healthcare Improvement Open School, where Dr. Armand was also serving as a coach, especially because he's from Francophone Africa and is French speaking. And he's a medical doctor and an improvement advocate for the longest time I have known him. And he has also founded an organization to help improve quality and safety within Francophone Africa. And I will let him tell us a little bit more about that organization as he talks to us. He previously led the IHI Open School chapter at the University of Antananarivo and served as a global chapter leader and coach for the Institute of Healthcare Improvement, supporting emerging leaders, particularly across Africa, in building local capacity, leading improvement projects, and fostering learning communities. He recently earned a specialized master's in management of healthcare and social organizations from Toulouse Business School, and deepening his commitment to transforming healthcare through education and collaboration. With that, you have the floor, Armand. Welcome.
Thank you, Mercy, for this kind introduction. And it's a privilege for me to be here with you and to share some few things I've learned and that I want to share with you. So let me share my screen first. So we will talk about the challenges and opportunities that we have while trying to build a culture of safety in healthcare institutions. So that's what I want to discuss with you today. But before we do that, I want to have a time also with you. It seems like today is the day that we will have a lot of story going back home. So this is a story of me doing a medical mistake, a medical error when I was in my 6th year of medical studies. To tell you the context, I was doing my OBGYN rotation in the hospital, and it was very late at night, and it was towards the end of the rotation, and we needed to do as medical students a certain number of deliveries for us to be able to successfully pass our rotation. So that night, I was taking care of a woman. It was the first time that she was about to give birth, and the labor was not going fast enough. So with the midwife, we discussed, and we decided that we will give her oxytocin to speed the process a little bit. So the woman was crying, shouting. As soon as the midwife said that, I took one vial in the delivery kit, I broke it, and I injected it in the saline solutions. The woman gave birth like a few minutes after that. And I was still the midwife took the baby, and I continued to take care of the baby, of the mother. 5 minutes after that, the midwife came, very furious and angry, looking at me and saying, "What have you done?" And I just looked at what I was doing, and I realized that I've injected the wrong medication to that woman. Luckily enough, the woman was fine. We intercepted the mistake before it could cause any damage, and the medication was not, it was vitamin K that was supposed to be given to the baby, and I've given it to the mother. So the nurse was very angry that day, but it's a nurse that I used to work with during my night shift. So she knew me very well, and she was very friendly with me all the time, except for that particular day. And she told me that, you know, what we are going to do is that you are going to remove that saline solution that is in the room of the patient, and you are going to change it with a new one so that the patient don't notice that the error happened. And I was shocked at the time, and I was fearful for the consequences of my mistake, because in that particular hospital, there are repercussions when you do something like that. But since the nurse liked me and she knew that I was kind of a serious medical student at the time, it was the first time. So she said that, okay, because it is you, what we are going to do is that we will handle it like that. And the incident was closed for her. The incident was closed for the patient, and the patient never found about it. I took the virus, I went home with it, and the incident was closed for everybody except for me. I know that you're probably wondering what happened next, but I suggest that we leave it at that first, and we will dive in, and I will come back to that story later. So today, as I said, we are going to talk about the challenge and opportunity in trying to build a culture of safety in healthcare institutions. Fortunately enough, since I'm the last to pass, I will not have much to say about the background part of it, since I think Dr. Rochfort touched a lot about definitions and things like that. But I want to just read this quote, which is from Florence Nightingale, which is one of the founder of the patient safety and quality improvement movement. She was a nurse. And she said that the very first requirement in a hospital is to do no harm to patients. I think everybody knows it. That's, we have to make sure that the patients are not injured by the care we are trying to provide. That's the basis. And she said that because even today, she said that a very long time ago, but even today, studies and data shows that patients are still hurt by the care that you are providing to them. And especially in low and middle income countries. As Mercy said, in the last time, when I was working with ICHA, I decided to focus on the Africa region. And now I even focus even more on the French-speaking countries in Africa and in IT. So we know that in Africa, for example, in our region, we still have a high burden of hospital-acquired infections. That's not a secret. We have up more than 20 times the rate of hospital-acquired infection than compared to the developed countries in the world. The death and alarming rate, some studies suggest that it's up to 2.6 million deaths per year due to unsafe care in low and middle income countries. So that's not a secret. Everybody knows it. Somebody that has worked in the hospital for at least 1 year, I've already realized that sometimes the care that we are providing is causing more harms than good. But there is a good news also with that, because since we realize it, there are activities that have been done to try to prevent it. And it has led to the field of patient safety science and quality improvement science, which is very well known. I will not take long about it because Dr. Rochfort exposed it very well. But I just want to mention that this science works. It is proven, even in our setting in Africa where we don't have resources, people will complain that we don't have enough. And there are countless examples of quality improvement projects doing great things in Africa. I just want to show you this. It's in French, but the line in red is the bleeding after delivery. That's the rate of bleeding after delivery that certain women were having in an hospital in Niger, that is in West Africa. And they did this quality improvement project. The arrow that you can see here is the beginning of the intervention. And as you can see, there is a drastic reduction of hemorrhage after delivery, which is one of the first leading cause of death of women giving birth in Africa. So, and I can share the study with you, but when it is done, they have been able to do that just because of a cooler, because they've realized that oxytocin in Niger is very hot, and oxytocin is something that is it's not effective when it's exposed to heat. So in that particular hospital, there was no money to buy a fridge. So what they decided to do is that they bought a lot of container of cooler, and they put the oxytocin inside the cooler. They trained the staff to use it and to pre-fill syringes and to put in the coolers, and they were administering oxytocin to the women, and this led to this result that we are seeing here. Sometimes we had zero hemorrhage after the delivery in that particular hospital with no resources, just with the science of improvement, analyzing the problem, suggesting solution, and implementing it. So we know that it works. We know it works. And if we have to put it in the hospital, you have to build what we call safety culture. There are many definitions for safety culture, but I will say that a positive safety culture is implemented in a hospital when, in that particular hospital, everyone, from the director of the hospital to the youngest nurse, prioritize the safety of the patient over all competing priority in that hospital. It's a set of shared value, the belief that the science of safety works and that they need to implement it to reach a result, better outcomes for the patient, a set of norms, a set of competency, a set of protocol that needs to be put in place to make sure that the patient is not hurt by the care we are trying to provide. So safety culture has certain attributes when it's implemented in hospital. That's just background information. I think you can recognize an hospital where there is a safety culture where people prioritize the safety of patient over or any other thing. When the leadership is committed to that, when the leadership of the hospital has made clear to every new employee and to every existing employee that we will have zero harm to patient in our hospital, and they put resources to help the staff achieve that goal. They put time, they put training, they put money in order to make sure that the patient are not injured. There is open communication and psychological safety. That simply means that people are free to talk when there are problems in the system, where people don't hide mistake because they are in fear of being chastised because of the makeup. Because when you start to hide medical error, the system does not improve. So punishing is a very bad idea for patient safety. That's a well-known fact. And it's also a system where there is a non-punitive response to error, what we call a just culture. I always used to joke when I was talking with people about patient safety and saying that there's no healthcare professional that wakes up in the morning and say that, oh, what if I change the medication of the patient in room C today? Or what if I do something that can endanger the life of the patient today? There's no healthcare professional that does that. Healthcare profession generally attracts people that want to care for people. So punishing staff for mistakes that are mostly due to system failure is unjust. But it's still something that is done in places where there's not a positive safety culture. Of course, we have teamwork, learning environment, a place where we learn from mistake and not punish people. About the non-punitive part, if you look at the news, you will still see some countries in Africa where healthcare personnel is put in prison because of a mistake. That's not happening in a positive safety culture, because people are just based on their behavior, not on the result of what they have done. Because it's scientifically proven, most mistakes, most errors that happen in the hospital are the result of faulty systems and not faulty individuals. So those are background information. Those are things that we know. So the question is, if we know that it is effective, why? Why is it not widespread? Why is patient safety still stalling today? And I can still lecture you about the reason, the challenges that they face, but I think that it is very well documented in the literature. This is just one example among the 100 that I could find about patient safety culture in African health facilities. So I can do that, but I will just invite you to Google it and to type it and to read about it. It's very interesting research, and there's a lot that's been written about Africa. But today, I think I will tell you more about my personal experience and my personal story, the things I've done to try to change things and the challenge I've encountered, and I hope that maybe will inspire some of you, because I'm still a young medical doctor, by the way, and I started this very early. I graduated in 2017. But coming back to the story I was telling you about in the beginning, when that nurse shouted at me and then decided to cover me, I took that vial of saline solution in my house, and I think I kept it for about a year. And I thought to myself that I will put that vials on my study desk, because I want to remember every single day when I'm going to the hospital that I have to be careful. I have to pay attention. So that was my ritual, actually. And luckily enough, one day I found online a course about quality improvement on Coursera. I don't know if you know, but it was taking the lead of quality improvement. And during the course, they talked about the Institute for Healthcare Improvement. And I went to the website. I've seen that they also had some courses. I took the courses, and then later on, I fell in love with the discipline. I realized that the mistake that I made that day, yes, I did a mistake, but I was not entirely I was not the only culprit in the story. There were many system failures that led to that particular moment. First of all, for example, let me just give you 3. That particular day, I've later learned that there was oxytocin in the hospital was out of stock. So the pharmacy couldn't supply oxytocin. So they were delivering the delivery kit, but without oxytocin. And there was the information was not well communicated amongst the 2 units. So I wasn't aware. So were many of my classmates at the time. That's the first thing. The second thing is that in that particular hospital, the vial of oxytocin and the vial of vitamin K look similar, actually. And it's a medication that people are using like every day for women and babies. So, and that is a well-documented error, actually, that happen look-alike medication and sound-alike medication. So that is a latent error, as we call in patient safety, an accident waiting to happen. And also, I was tired. It was 3 a.m. and the service there was kind of a competition between medical students, because we had all goals of doing a certain number of deliveries, but not enough women entering in the unit. So there were like competition. If you are not standing next to the woman that is about to deliver, if you leave just for 1 second, you can come back and see your classmate doing the delivery and having the point instead of you. So there was this competition going on in the unit that may have also contribute to that happen. those are just the three. I'm not trying to say that if I have not paid more attention, it shouldn't have happened, but I'm just saying that there were contributing factors from the system. And the fact that we hid the mistake at the time didn't help the system to improve, actually, because all those latent errors were still present when I left the hospital that day, waiting for another person to commit the mistake. So when I learned all these things about patient safety at the time, I decided that I will try to share it with my classmate and my friend. And that's what led me to become, after in my 7th year of medical school, I founded and led a chapter of the Institute for Healthcare Improvement Open School in Madagascar. I did it for 1 year. And later on, I became global chapter leader and then IHI Open School coach, which I did for 3 years. And I met Mercy there. We served together for some time there. And during that time, my role was to get in contact with chapter leaders around the world. And later on, I had a special focus on Africa to help them to lead quality improvement projects in their communities, to create chapters, to promote the quality improvement science in their local settings. We did chapters personally in Egypt, Lebanon, Uganda, Ethiopia, and so on. So it was a very fulfilling experience for me to lead these leaders, to support these leaders as they were trying to create change in their local community. On the professional side, I practiced medicine in Cameroon. I went back because I was a medical student in Madagascar. After that, I went back in Cameroon, which is my country, where I practiced medicine for 2 years as a general practitioner and then as a medical director for 2 years and a half. And I went to France to pursue my specialized master in healthcare management. And now, after that, I created an association, which the name is in French, but globally is saying that it's an initiative to promote the quality improvement science in French-speaking countries in Africa and in Haiti, because we have many Haitians that are in the association. So our goal is to equip healthcare leaders in hospital in Africa, French-speaking country, to lead quality improvement initiative in their hospital, and also to teach even medical students about the science of quality improvement, but in French, because that was one of the problems that I had sharing, promoting quality improvement when I was in Madagascar. Most of the people around me spoke French at the time, and I was the only one speaking English. So it was difficult. I can share, but you have to take the course after all. So there was no resources available at the time for that. So that's what we are doing right now. So I'm finished with that during trying to do that, I encountered many challenges to do that. And I will share some of the challenges with you today. So the first challenge that I had was the lack of familiarity with the patient safety science. When I try to share my knowledge about patient safety science, I have one problem is that, and I think it's a problem in most of French-speaking Africa. I don't know. I know that in English side of the continent, there are people that are, how can I say, there are courses about quality improvement. But me, I never had any course on quality improvement in my medical school. I had to learn it online. So as my classmate. The second is the limiting belief people have about improvement. Some people think that, oh, error just is something we cannot do anything about it. There's also a cultural taboo about medical error in healthcare. Nobody wants to talk about it. Fear of being punished, fear of reputation, and things like that. So that was a challenge that I had to. And the fourth challenge I had is that the lack of power and legitimacy. Because yes, I took some courses online. Yes, I am coached with the Healthcare Institute for Healthcare Improvement, but who am I to try to make this revolution happen in the system? Even when I was general practitioner in Cameroon, I used to joke and say that I feel like I'm the general practitioner number 256 in this organization. Like, you are just a number. Nobody knows you. You don't have no power, no name. And who are you to lead this kind of work? So the way I will overcome those challenges and what I want to share with you, young doctors, because I'm sure that many of you are here today passionate about quality improvement and patient safety, and maybe you are encountering some of those challenges. So I will share with you what I did, and that may help you too. The first thing that I would suggest is to learn. Like me, I took online classes. At the time, it was not that easy. But now we have a lot of resources about quality improvement online. You just have to Google quality improvement or patient safety, and you will find a lot. There's the course of the ICHI, Institute for Healthcare Improvement Open School, still available, free for students in Africa, students and professionals in Africa, by the way. And for those who speak French now, in my association, we partner with an organization in Belgium, and they translated all the course of the Institute for Healthcare Improvement Open School in French. So that's something to look. The second thing is to practice. You don't need authority to practice. You can do what you can do at your own scale. There are so many things that you can do daily to improve patient safety. Hand washing, for example, using the checklist, for example. There are so many things that at your scale, in your unit, in your office, you can do. The third thing is join the community. You cannot do it alone. You need more people. Me, I found a community in my chapter that I created in ICHI with Mercy and other people. Join the community. You will have more idea and more power to act. And the fourth thing is form powerful alliance. As I said, alone you cannot go far. I remember one of the first course I taught about quality improvement and patient safety in Cameroon was because I met somebody in my community that was passionate like me. I think it was the Cameroon Home Care Services, a leader there, a woman, a doctor that helped me a lot. And we were used to discuss a lot about quality improvement. Me, I had the passion, and she had the connections, and she knew people that can make the thing happen. And because of her, I was able to teach like in a room full of leaders of many hospitals in Cameroon, and we had this session. So it's something that I couldn't have done alone. And even now, I'm still trying to partner with more powerful allies, so to overcome my imposter syndrome. And finally, that's my bonus tip. Be bold enough to be vulnerable. One of the things that I've noticed is that was the most impactful in me doing this work is that I've noticed that since medical error is a taboo, I've noticed that when I lead the conversation by sharing my own story of a medical error I made when I was a student, almost immediately people open up and they share also a story about the medical error they made. It's a burden that everyone has. You are not alone in this. So if you are vulnerable enough to start to lead by sharing, the conversation open up. I remember this intern in ICU who told me that yesterday I did a medical error. I gave also the wrong medication to the wrong patient, and I had to do a lot of things to make sure that the patient survived. And she was shocked at the time, not realizing that she's not the one responsible. There are a lot of articles about medical professionals, the second victim of medical error. Many people commit suicide because they did a mistake in the hospital. By being vulnerable, you invite the conversation and you open up the floor for the healing to start happening. So those are the tips that I want to share with you today, and I'm very grateful again for this opportunity. So I thank you for your attention, and I leave the floor to Mercy and to any other question you may have.
Wow, thank you so much, Armand, for that wonderful presentation and for sharing your experience. I love how you finished off with saying, be vulnerable enough to share your story so that you can empower others to be able to share theirs as well. Thank you so much, everyone, for joining us. We are now going to open the floor to any of your questions. We still have our earlier speakers here with us, Dr. Andrée Rochfort, Inés Sebastián, and Dr. Ettang as well. So I encourage you to just raise your hand and I'll ask you to unmute and ask your question. Or if you prefer, you can put your question in the chat as well. So I am looking. Oh, Jose, welcome.
How are you doing? So congratulations for this very exciting and thriving workshop. Webinar. We are enjoying it very much. And I would like to ask the speakers on how do they think quality and patient safety could be in 10 years' time with the eruption of the AI, machine learning, and all these new technologies? Would that change how we tackle with our daily consultation? Will it be very different? And what are their advice, the piece of advice for us? Thank you.
Thank you very much. I don't know who would like to take that on.
Thank you so much for your question. So yes, machine learning, AI, unfortunately or fortunately, is here to stay. And it's about leveraging it to support your practice, not to replace your practice. Remember that AI, well, some AI seem to have empathy when ChatGPT is replying to certain things that you might give as prompts. You might ask him to say, reply, include empathies. But at the same time, it doesn't replace you as an individual. Where does it help a lot? There's one I use for now for my consultations. I'm not trying to promote a product, but it's called Chat Notes. And what it does is that, well, with your permission, it's actually a HIPAA accredited platform. You have your consultation, it stays in the background with your patient permission, and it records the consultation. Okay. At the end of the consultation, in less than 5 minutes, it summarizes that whole consultation while giving you the audio of the recording and picking out salient points of it. Now, can it be misleading? Absolutely. So obviously, you're going to still check back what is written there. Is it here to replace you? No. You can still write your notes manually if that works better for you. So it's just about saying that we are here to stay, but how can we use it with safety and would not compromise patient data and the patient's information, but also leverage our practice so that we can be more efficient and do more. I'm not sure how practice is there, but this is an average. When I was working for the public sector, I was given in a day, I had 4 hours and I had 30 patients. And you're not only just consulting and, okay, well, I mean, for us, you're consulting, you're also dispensing because you have a small room in the rural areas, so you have to dispense. If you're taking blood, you are also the phlebotomist, you're taking blood from that patient. If you're making referrals to the regional or provincial hospital, you're also going to make that phone call to make that referral and write the referral letter and do all of that and see all that amount of patients within that short window of time. Now, so how can we make technology work with us, not to replace us?
Thank you, Dr. Ettang, for that and for giving that wonderful example of how AI supports rather than replaces. I don't know, Dr. Rochfort, Inés, do you have any comments around AI and technology in the next 10 years and how that will affect quality and patient safety in primary care?
I think I'd really like to hear the younger, earlier career doctors' views on this. I agree. It's here to stay. It's something that is already incorporated into many of the things many of the technologies that we use in medicine today. Where it's going is, who knows? But the most important aspect of it for me is that it does not increase the workload of clinicians, but that it should assist and support the areas of that are very time consuming that can be done by technology.
Thank you very much. I think that's a very important perspective, that it supports rather than makes it harder for clinicians to do their work by giving them extra work. So I think that's a very important component, because that extra work is what sometimes also leads to errors as well, because of fatigue and being overwhelmed. Inés, would you like to say something as well?
Yeah, I totally agree with Dr. Ettang. I think one of the most important things we have to deal with is confidentiality. I would say the last years we've been talking through ethics, because some of the information we're dealing with the AI, we are not sure what this information is being used for. So what we have to make sure is that the programs we're going to use in our in our days in the health centers and hospitals, that this medical information is not going to go to any other place, and to make sure this remains confidential so that we work in a safe way. I think that's one of the most important things I could highlight. And of course, I think that it's something that is already here, that is going very, very fast, and that we will have to learn how to get the most out of it.
Thank you very much, Inés. And I think that is something that I'll just highlight that I've seen come up over and over again in today's conversations. The safety aspect, the safety aspect that has to do with confidentiality and privacy of information as well. That's an important angle of patient safety, and also the quality of care that we give that sometimes gets forgotten. So thank you for bringing that up and for reminding us about that having that information secure, having it private and confidential is also a very important part of patient safety. I'm just going to highlight some comments I've seen in the chat around the issue of having a culture of a non-punitive culture in hospitals. I know that Michael commented earlier on how, especially in the Africa region, where everything is just blame, how would it be made possible for young doctors, young family doctors and GPs coming up to be able to share their stories? That's one. And then two, what can you say about the perception of a non-punitive culture, especially in hospitals?
Could I begin the conversation by talking about having a safe place? It was wonderful to hear Dr. Tiam talking about being vulnerable and opening up about medical error. And I agree there are challenges to opening up about medical error. It's not just in Africa, it's globally. The challenges are especially if the stories are spread and are misinterpreted. However, Dr. Tiam is absolutely correct that some doctors are very psychologically burdened by fear and by their stigma at having made a mistake, and that they are burdened, whether it's an actual error or a perceived error. They are equally burdened. But I believe as part of the support of practicing doctors, that all doctors need a safe place to discuss these incidents, which are often called second victim incidents and experiences. They need a safe place. We all need a safe place with colleagues in a confidential, safe place. So just as the patients need confidentiality, doctors also need spaces that are confidential and safe to discuss their experiences and receive support from their peers.
Thank you very much, Andrée, for that. I think that's very important, reminding people that it's not just the institution that we think of as a building that needs to create the safe space. It's us, peers, and colleagues that can create that safe space for people to be able to unburden themselves and to talk about these errors and how they've affected them as the second victim. Because I think Dr. Tiam shared a very good example of how it affected him for a whole year. He was reminding himself of it. So I think that's a very important perspective, which answers some of the questions in the chat, the issue around how do we create that culture, and it starts with us. Inés, did you want to say something? Okay. Dr. Ettang, oh, Pilar, thank you. Yeah, go ahead.
Hello. No, just to add some words to what Andrée Rochfort said before. And well, first to congratulate of the lectures, because I think Inés, Enwogo, Armand, you propose inspiring presentations based on your own professional experience and direct experience, and how to overcome difficulties through learning and striving to improve quality and safety of the care. So it's really challenging, but we have to start doing so because it's your professional career that is starting, and learning from real world experience to improve is the best way. And you can count on us, on WONCA membership, in your journey as family doctor, of course. And then regarding the second victim phenomenon, we have to consider those topics that my colleague said before, that is the confidentiality, the safety place to talk. So to do an effort for safe places in our practices, to have time to talk about these situations, not only when things get really wrong, but sometimes with mild things that help us to learn how to analyze, to learn how to talk to our colleagues, and remembering that the first tier to help a colleague is ourselves, means we are the colleagues that can help them to provide a place to talk and follow our colleague as well, giving support, and in case we need more complex support, then we can have the college support. There are a lot of colleges, professional colleges, that offer support for family doctors regarding the second victim phenomenon, but as well sometimes regarding legal issues and other situations that might happen. But we, the mates, the colleagues in the practice, we are the first tier to support them, and we have to be there and to ease these talkings. So then we create safety culture among us, building these teams, and then we will have this non-punitive error, non-punitive culture in our institutions, because it's a bottom-up situation that we will need as well some regulations at national level, but we are from WONCA and from other organizations struggling with that policy advocacy on transforming some regulation, as already have been done in some countries, like recently in Italy, but in sorry law in US, in some departments in USA and in other countries. But the first tier is ourselves, and the
Thank you so much, Maria Pilar, for that. And I think you've also answered Michael's question, where he was asking, how do we deal with institutional factors that threaten patient safety? You've mentioned the issue about national regulation, creating that culture of safety, and as peers coming together to work around ensuring we don't have a punitive culture and supporting each other. You've also talked about the communities like WONCA, where you are here to support young doctors. So Maria Pilar and Jose Miguel are part of the executive committee of the WONCA Working Party for patient and quality for quality and patient safety. And at the end of this, I'll let them tell you more about it, and also how you can join. I am part also of this working party, and I can say I've received a lot of support and also learning from them. So it's a wonderful place to be, to just find community and somewhere where you can discuss these issues and find support and guidance also in leading quality and patient safety initiatives. So if there are no more questions, I'll invite Jose Miguel, and then again, Maria Pilar should just talk about the WONCA Working Party for Patient Safety, and also to let the young doctors know how can they join, how can they be part of this great community.
Well, WONCA World Working Party on Patient Safety has more than 20 years experiencing helping doctors to learn and help other doctors with their quality and safety problems. We meet, the executive meets regularly, and we are holding webinars as well as workshops in the different WONCA world regions. And we will run several workshops now in WONCA World Conference in Lisbon. We have also a web page and social media. I have been sending tweets and tweets of this meeting, and we will post the link, because this is a webinar that is being recorded, and if we manage, we will also send 10 or 20 seconds videos with some tweets for those who have not been able to join us, just to help them to visit WONCA webpage and visit this webinar. There is an address that will also be there, with which you can join us to join the group, and you are welcome for sure. Jose Maria Valderas, which is the chair, has not been able to join because of some previous meetings he had at the same time, but he would like also to transmit his warmest welcome and thank you to everybody who has been in charge presenting, or you as this wonderful chairing you've been doing. Mercy. I give the floor to Maria Pilar. Also, Andrée Rochfort is in the executive, so she can say a few words if she wishes.
Thank you very much, Mercy and Andrée, to organize this AfriWon webinar for sure. I think it's really important to have spaces to transmit our knowledge and to the know-how on quality and patient safety, to have new leaders in family medicine and patient safety and quality. I always believe in making the work together, not alone. So therefore, driven by this need to connect with others who share an interest in quality and safety, I first joined the Patient Safety Working Party of the Spanish Society for Family and Community Medicine, SEMFIC, in my country, though through SEMFIC, I became involved in equipping the patient safety and quality in family medicine in WONCA Europe, and therefore I joined later WONCA World Working Party on Quality and Safety with Jose Miguel, where I continue to learn, to collaborate on various projects, and to grow both in my own practice and in mentoring future family doctors, including residents and medical students, and having a continuous learning approach with my colleagues who share the same values and the same way to analyze reality and try to make improvements along our professional performance. So we invite you to join our WONCA World Working Party or a WONCA Euro Working Party, depending on you where, or even to create a WONCA Africa Quality and Patient Safety team who can address as well more specifically your needs. I was just listening with care to Armand, who put on the table the question of languages. In Europe, we have had different French primary healthcare quality and patient safety summer school in France for several years. Was our beloved Isabelle Dupuy who ran these workshops and summer school for 3 days to help young doctors to develop the quality and safety improvement projects in their practice. And I think it could be a good idea to try to implement this kind of summer schools or webinars in different languages in certain way to give the opportunity to all to have a learning process on quality and patient safety in primary healthcare. So I think we can have a thinking on that and perhaps making it reality in some months. Thank you.
Thank you very much, Maria Pilar, for that and for that invitation and for all the initiatives that you've let us know that people can be involved, the young doctors can be involved in. And now I'm just going to do a 1-minute round to all the speakers and then finish up with you, Andrée. What is your parting shot for us today? I'll start with Dr. Ettang, then come to Inés, then Armand, then Andrée. Dr. Ettang?
Sorry, my network is messing up. I just want to say thank you everyone for being here. I'm really honored to be in the panel with all these amazing people. And I believe that even from the different vantage points where we're seeing health and safety, we can be great advocates for pushing both quality healthcare and safety for our patients, and also for getting us too, because burnout is real. And as is actually, they've all mentioned, sometimes some of our medical mistakes are born from our burnout, our physical fatigue, dealing with workloads, mental health challenges, emotional, family, and stuff. So looking for a quality and safe environment for both the patients and the healthcare providers. Thank you very much.
Thank you so much, Dr. Ettang, for that and reminding us to take care of ourselves. Inés?
Yeah, thank you very much for being here and for letting me being part of this interesting webinar. I think I agree with Ettang. I think that it's important to highlight the health of the medical workforce and the rest of professionals that work with patients, and also make sure to give them the tools to deal with these type of situations, and especially with health problems that may affect their daily life, their work, and their own health. And of course, what they just said, I totally agree. So thank you.
Thank you very much, Inés, and it was also very wonderful to have you with us today. Armand?
I guess it's my turn now.
Yes.
Okay, thank you. I don't have much to say. Most of the time I've been silent, listening to all the presentation, and I was blessed to listen to everything that was said in the beginning. I think that I'm truly honored to be among the panel talking today. Is truly an honor, and I think initiative like this one for young doctors, especially something that I still consider myself as a young doctor, but it's something that when I was coming out of school or when I was in final years of my school, I didn't necessarily have been in a community of people like me with the same struggles, with the same experience, being able to share in a safe space, as it was said. So I think it's a blessing for them to have this kind of opportunity, and even for me, and I hope that this kind of opportunity will multiply. The more we talk about it, the more people are aware about it. And I think the change will start happening from these kind of interactions little by little. So I'm very hopeful for the future of patient safety, especially because of events like this. And I hope that maybe in the next 10 years, the doctor who will graduate will all know the science and will not suffer the burden that we had. They will have other burdens, I'm sure, but at least if we can spare them this one, that will be great.
Thank you so much, Armand, and for reminding us about the importance of community. And now finally, Andrée.
Thank you, Mercy, and thank you for bringing together these three wonderful early career GPs, Dr. Sebastián, Dr. Ettang, and Dr. Tiam, to share their perspectives. And I think with you, Mercy, and with Maria Pilar and Jose Miguel, I think you'll agree that we're very lucky in the WONCA World Working Party on quality and patient safety to have these three young leaders speaking to us about safety and quality here today. They've covered many topics, including how clinician health, telehealth, and safety cultures can interact with healthcare quality and safety in family medicine. And I would like to echo what Dr. Tiam said. We cannot do this work alone. So I think the future is very bright. Thank you to everybody.
Thank you so much, everyone, and to our lovely audience who've taken time off their Sunday to join us. We say thank you so much, and we hope you have benefited as much as we have from these wonderful conversations. Do visit the WONCA website where a recording of this webinar will be posted, and also look out for more information from the Working Party on patient safety and quality, and also from the Young Doctors Movement from WONCA on further webinars and any other information to follow. And with that, I wish you all a wonderful, whether morning, afternoon, or evening, and also a very blessed week ahead. Thank you very much, everyone. Bye-bye.
Bye.
Bye-bye. Thank you very much. Merci.
Bye.
Andrée, bye.